Hello, my name is Julie Boyce. I'm a student at United States University. Today I'm going to be talking about post-herpetic neuralgia. FNP 596, Professor Stolzer. Let's begin with what is post-herpetic neuralgia and where did it come from? Maybe just a little bit of background information that I will give you throughout the PowerPoint. Post-herpetic neuralgia is the most common complication of shingles. Its persistence of the pain associated with shingles beyond 1 month, even after rash is gone. It's a condition associated with constant burning or aching pain, intermittent shock-like pain, in response to normal non-pain stimulus. And I have listed other symptoms that can be associated with varicella zoster because this is the beginning of post-herpetic neuralgia. And we all know shingles to be causes of chickenpox and can cause a number of neurological disorders, such as encephalitis, meningitis, polyneuritis, multiple cranial neuropathy, and Rye syndrome. And I just wanted to hit some of the highlights of those because this is a serious condition with sometimes it's go on left untreated. But as we go on throughout the PowerPoints, we will hit some of the highlights. This can occur even after the rash is gone. Most of the time people have pain with the shingles, but this is an ongoing condition after the shingles have cleared up. Throughout the PowerPoint, I will be referencing to post-herpetic neuralgia as PHN, so that way everyone would know if I say PHN what I'm talking about. Let's talk about the anatomy and physiology of PHN. Pain associated with varicella zoster, known as shingles, comes from the destruction of sensory neurons in a ganglion. And we know a ganglion is a number of nerve cells. Pain usually goes away in a few weeks. However, if the pain is still present after a few weeks, then it's known as PHN. This pain usually develops as a result of shingles, which is the primary infection, and or chickenpox or a late reaction of herpes zoster. Most common complications can last for weeks or years, and that's a lot of pain. And nerve pain is not easily controlled either. Neuralgia is neuropathic pain that occurs along the course of a nerve, and we see this sometimes in our diabetic patients as they get neuropathy. They have that pain, which is like a burning sensation, and they often complain of numbness. I had a patient in the clinic yesterday that has been diagnosed with neuropathic pain from originally from diabetes, and also this can occur in patients who have back injuries too. They can get that neuropathic pain. It tends to happen when an irritation or damage to a nerve alters its neurological structure or function. And we learned in anatomy and physiology about how the nerves can be destroyed with different diseases. So PHN has been added to the list, and I just wanted to hit this because I wanted to learn more about different types of chronic illnesses besides hypertension, COPD, etc. Which there's nothing wrong with those, but I know it's beyond just the basics. Next, we have the epidemiology overview of PHN. There are more than 1 million new cases of herpes zoster in the U.S. each year. And I may refer to herpes zoster throughout the PowerPoint as the shingles because we are mostly familiar with the shingles, but it's good to know the other medical terminology associated with it. It affects men and women equally, approximately 30% of individuals. That means it has no discrimination when it comes down to who this illness attacks. It also affects immunosuppressed due to a disease such as HIV, chemotherapy, or radiation. And it could also affect our sickle cell patients too. Um, Anybody that has immunosuppressed condition can be a candidate of herpes zoster. It is estimated that about 1 in 5 patients with shingles will go on to have the um, PHN, and that's a lot. If you got 1 in 5 patients, and you're talking about 1 million new cases a year. The risk of post-herpetic neuralgia increases with age, primarily affecting people older than 60. However, the shingles affects people 50 and older. And even if you have had the chicken pox, um, a person can still develop the shingles. And I tried to find some pictures to show a combination of men and women, and I really liked the little picture in the upper left corner for some reason. I thought it was. In order to properly diagnose these patients and to make sure that we are all on the same page, um, is the clinical presentation. The presence of lesions, neuralgia is, the neuropathic pain that occurs along the course of a nerve. So if a person is coming in talking about pain and you see a rash and it just follows a pattern, you can almost come to a conclusion that it's going to be shingles. I recently had a patient who complained of having a runny nose, stuffy head, ear pain, and was told to come by so he can be evaluated. And when we saw him, it's amazing that he never mentioned the rash that was on his face, but he did describe the pain that he was getting in his head as like electric shock, which often people complain of that type of pain when it's on their nerves, like somebody is shocking them periodically. Well, he was diagnosed with shingles, and we went on to provide appropriate treatment for him. The eruption of the rash, it can be on one side of the body. It may be present after lesions are resolved. The pain, may still continue. They can also be depressed, fatigue, insomnia, because when they're having this type of pain, they're not going to be able to sleep. This patient that I recently spoke of, he was complaining of head pain, and it was happening on the side that he likes to sleep on, and therefore he was not sleeping, which can lead to fatigue, and often it can lead to depression. It's a good thing that he didn't miss any work. He's 68 years old and didn't miss a day of work, but he was complaining of not being able to sleep. Maybe atypical in immunocompromised patients, means not a normal pattern. Like we may see in a healthy person, it may just be a nice little rash along the nerve, but in a person who may have HIV, it may be all over their whole body. So we have to make sure that we listen to the complaints and try to properly diagnose these patients so they can get treatment. What can cause PHN? As we spoken earlier in the slides, herpes zoster, shingles, known as the varicella zoster virus, causes the shingle outbreak, and the pain comes from the neuropathic system, where the nerves inside the nervous system are aggravated. It's not caused by an outside stimulus such as an injury. So we have to make sure we ask the patient, did they fall? Have they had any recent injuries? Did they bump their head on something? People often refer to it as a pinched nerve or a trapped nerve. The nerve itself sends pain messages because it is either faulty or irritated. The pain can be severe and debilitating. As I mentioned before, it can occur in persons as early as age 50, and it can go on and on and on. So that what makes it a chronic illness, because these people have to continue seeking treatment for even after the the rash and the blisters has cleared up. And we want them to feel comfortable coming to us, because we don't want them to feel like they're just running to the doctor. We do have some patients just come because they're lonely, or they come because they don't have anything else to do. But if we have people that come in that are really trying to live a full life, work and manage children and family, and pay bills and everything, we want to make them feel at ease that we understand this is a real condition for them, and give them a diagnosis, give them information on it. How do we diagnose and evaluate these patients? First of all, our documentation is going to be very important in taking care of patients with shingles, because of the development of PHN. We want to do a clinical, thorough, several laboratory testing. Tests are performed when the vessels are en route or full fluid collection. They have, I don't really know how to pronounce this, but I'm just going to take a hit at it, and just the Zax smear, which is a rapid turnaround, but depending on having stains available in a skilled interpreter, will be whether or not you'll be able to use this particular test. A fluorescent antibody assay distinguished from herpes simplex, because we don't want to give the wrong diagnosis. We want to make sure, even though the treatment probably be the same with the acyclovir or the antivirals, but we want to make sure that we are diagnosing them with the proper diagnosis, just in case the pain doesn't go away in a few weeks, because that's what's going to lead to the PHN, and like I said, from the documentation, we want to make sure that we're putting the right documentation, so when these patients comes back, if they have to come back to us and say, hey, I'm still having this pain, I'm not sleeping, I'm depressed, I'm getting irritable, we don't want to be like, oh, they just overreacting, or I don't know what else is going on with them, maybe let's do this. We don't want to run a big bill up for the patient or the insurance company, because we forgot to put in, oh, they had shingles, or we forgot to do the proper test. And the reason why I say this, because as I go through some of the charts, and when I'm taking care of patients, when they come into the clinical setting, I see a lot of patients that history is not in the system. We can get the visit that they came in for is in the system, but I've seen patients who say, I've been diagnosed with this condition for a long time. I don't know why it's not in the chart. And I'm sitting there thinking to myself, I don't know either. But also we can do viral cultures. And I put in differential diagnosis from chest pain, because patients who often have the shingles in certain areas will complain of chest pain. So they'll start having the chest pain before the rash and the blisters appear. So if they come in with chest pain, then I know we're going to go ahead and do what we need to do with that. It can also mimic other skin problems, and I think I saw in the book that it was saying it can mimic impetigo and other conditions like atopic dermatitis. Also, neurologic impairment. If they are saying I'm being confused, I'm having a headache, notice symptoms of other illness that can cause neurologic impairment. That way, they can get treated quickly, because we don't want them to end up with a long-term disability from another condition. If it's in the eyes, along the eye, you're going to get them patients out quickly to maybe to the ER or maybe to an ophthalmologist. I mean, same day treatment because they can lose their eyesight. Um, and watch your population, the older patients, and like I said, improve your knowledge base because like I said, this is a real condition, and we want to make sure that we are treating patients appropriately, which I feel like we are learning a lot through USU. So plus reading for extra knowledge is going to be good and beneficial, and once we get out and start practicing. Now we're down to the treatment. Of course, we always want to do preventative care by offering the varicella zoster vaccine, make the correct diagnosis. Sometimes they may have to have a sympathetic block where they go in and block the nerve signals. Sometimes they may have to have a systemic cortisone shots. And remember your diabetic patients because anytime you introduce steroids to a diabetic patient, it's a chance that blood sugars can go up. Sometimes they may have to take gabapentin, anti-seizure medicines, also tricyclic antidepressants. We need to make sure we know the risk for each of these drugs because um, they do have side effects. And then we don't want to forget the opiates. Even though we're trying, I know we're in an opioid crisis and they are really strict on um, not prescribing opiates. But in the beginning, these patients may have to require opiates, and then we slowly have to wean them to something else because it's very difficult to titrate for pain control on the opioids. And I remember I had a patient who said that she was on gabapentin, and she was like, "This medicine don't do nothing for me." And so the doctor told me to ask her, do she want to stop taking the medicine just to see how much it's working? Because a lot of times people don't realize a medicine is working for them until they come off of it. And she was like, no, I do not want to take that risk. So and I remember us learning earlier that we may not be able to stop the pain completely, but if we can get the patient to a comfortable lifestyle where they're still able to get up and do the things they need to do, then we are doing what we're supposed to do. So the treatment plan is going to be titrated to the patient, of course, but prevention first by offering the shingle vaccination is all. Educate and provide information interventions. That's educate. Educate the patients um, intended to obtaining the vaccine because I have patients who come in and say, I don't want it. And then I have patients say, okay, I'll take it because it says, I saw a commercial on TV that says that if I take the shingle shot, I won't get the shingles. And that's not true. We need to make sure they understand that it decreases their chances of getting the shingles, and also if they do get the shingle, it lessens the effect of it. They can still get the shingles even after getting the injection. Let's make sure they know their options. We want to make sure we tell them to avoid babies and pregnant women because it increases the risk of chickenpox and shingles in pregnant women and babies because they may not have been exposed to the chickenpox yet, and we don't want them to get this because it can kill them. Provide written literature. Refer to a specialist if needed, ophthalmologist, neurodermatologist, to help assist in treating these patients. And know their pain expectation. Let them know that it's going to be painful. Some may be able to tolerate it more than others, but they need to know their pain expectations. I think one of the hardest lessons that I have had to learn in my nursing career when taking care of patients is not to be judgmental. Because in the beginning of my career, I was taught if a person is calling for pain, you wait a few minutes because if they're really in pain, then they'll call back. And until I was on the other end of the receiving the pain medicine. Let's not judge these patients. Let's try to help them. And I'm quite sure everybody that's involved in this really will do what they're supposed to do. Educate, 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 because we want to prevent the outbreak. And even sometimes after education, it's still people still may refuse it. Diagnose quickly. Have appropriate treatment like a SOP, a standard operation procedure, on certain patients that may come into your clinic. Thank you for watching my PowerPoint. These are just the references. Thank you and have a good day.